Hey everybody, welcome. Thank you for joining us, and I hope that we'll have a good discussion today. And thank you for being a part of what we try to do at SGInnovate, which is to encourage discussion, debate, dialogue on important topics. Our goal is to try and not get to a right or a wrong answer, because in many cases that's perhaps not even possible. But what we do try to do is to have a discussion that we hope moves the agenda forward. So when we talk about things like data, use of data, inevitably there's a number of concerns and questions. Privacy, anonymity, what happens if something goes wrong. We also take the other side of the discussion, which is how do we improve things if we don't better utilize data. So we'll explore some of these. Our goal is to make sure that you are active contributors. And so please, we have Slido, and there's the good old-fashioned technology of just raising your hand and shouting out your question. But what we'd like to do is make sure that it's not us just sort of presenting or having a conversation amongst ourselves, but instead you're active and involved in asking whatever questions you'd like. So could not be a more critical discussion around anything that does not include health and technology. I don't see any universe, personally, I don't see any universe in which those don't become closer and closer together. Have been through history, are today, and I'm sure inevitably will continue to become closer. And so this is an important topic for us. What I'm going to do is, if you'll bear with me, I'm going to do what I always do, which is ask for us to have our "we were here" memory moment with my colleague taking a quick pic, and then off we go, because we do like to tell people what we're talking about, because we do want people to be engaged offline as well as in these particular sessions. Second thing is just, I'm putting in a request. We have lots of really cool entrepreneurs, entrepreneurial scientists in Singapore, lots of companies that are being formed and funded, including some from SGInnovate, including some not. But if you're interested in being a mentor, an advisor, a coach, then we've got lots of really ambitious young men and women that are trying to build deep tech startups. And so I'll just put out a call that if anybody's interested, please let us know you're interested, and we'd love to get you involved, because there's lots of activity and we need more people that have some experience that can help coach and guide some of these young men and women. Okay, this is my teammate Tuan. If everybody will take a minute and just jump up and do the whole like "we were here," and if you're not comfortable, then look to the right or left or straight down, and then your face won't be shown. Okay, off we go. Okay. We can only do it if we're standing up, though. We're not doing this whole like seated thing. We go. Okay, what I'm going to do is invite my esteemed panelists, and we've got some really cool people that are here with us. And I'm going to ask everybody to introduce themselves, so I'm not going to go through it all. But what I'm going to do is, in no particular order, ask Farhana and Steve, Prosenjit, and Josip to join me on stage, and off we go. So please, everybody. And I've got Slido open and eagerly awaiting your input. And while you think about what questions you might have on your mind, I've got some. Let me go ahead and frame the discussion just for a moment. And here's some notes that I've made for myself. We do have some serious health challenges facing the world. It was just on BBC Radio yesterday. It's been a lot in the media. The disease-resistant, or I should say antibiotic-resistant malaria spreading from Cambodia and other parts of Southeast Asia around. And it's a significant and increasing problem, this idea of antibiotic-resistant disease, and in this particular case, malaria. The WHO declared Ebola in DRC, or Democratic Republic of Congo, to be of international concern, a public health emergency of international concern. We know very well diabetes and heart disease and obesity are significant challenges today, and increasingly so in many countries. And this idea that with an aging population, chronic conditions, one or multiple chronic conditions that people have to manage over many, many years or decades. So we have all of these different things underway. clearly the costs associated with treating all of these realities. And so inevitably, what's the role of technology? And how do we want to think about technology, and how can we better manage and allocate a finite amount of resource? And so part of our goal today is to explore some of that, and you'll see based on their descriptions that we have people that are subject matter experts in different areas. And so what I'm going to do is just start from my left and just ask each person to take a moment to self-introduce, and then we'll jump straight in for the discussion.
Hello. Myself, Prosenjit. I work with DXC Technologies, and I'm engaged with ministries in ASEAN as well as some large healthcare settings in consulting them on digitization of healthcare, use of AI/ML in operations as well as clinical spaces, disease registries, geospatial surveillances, stuff like that. That's my specialty. Thank you.
So I've been a physician for 22 years and ventured very early on into health systems research. How do you improve health system? First in Slovenia, where I'm from, and then moved to Imperial College in London, where I was until I moved 6 years ago to Singapore. And one of the key challenges for health systems for the last those 20 years, at least, is how they digitally not just convert, but transform. And it's been everyone's underestimate how easy that or how difficult that is. And it's going to be, at least for the next 20 years, continue to be that challenge and opportunity.
So good afternoon, everyone. My name is Farhana Nakhooda, and I'm newly joined a company called Health Catalyst. I've been there the last 3 months, and I'm heading their Asia-Pacific practice. Just 2 seconds on Health Catalyst. It's a data analytics, or I would actually like to say it's an outcome improvement company that uses data to drive outcome improvements. And the way that we measure our success is basically on millions of dollars saved or lives improved. Prior to this, I was actually with IBM, and I was with them for 18 years as their healthcare life sciences leader across Asia Pacific. And prior to that, I worked in biomedical research. So it's a real pleasure for me to be here today with this esteemed panel and share some of our perspectives on really the role of technology in pop health.
My name is Steve Tucker. I'm a practicing physician, an oncologist. Shockingly, I've been practicing 25 years. It's really kind of frightening. And it's always been the same. It hasn't changed as much as we want. But I'm a preventive oncologist and fairly obsessed with not just treating cancer, but looking at solutions for preventing it as well, which over the last decade has led me to roles in population health for telcos and insurers. And currently I have a role at an insurtech startup, AI health startup called CXA, where we can implement the ideas that have been ruminating in my head on a larger scale for prevention.
Cool. And for those that don't know Steve is one of the most quantified self individuals that I know, and is always interested in tracking things that are happening real time in his body, and I always learn a lot from Steve. So I think this idea of stay well versus get well is something that I hope we can also explore a bit.
I would notice that 3 of the 5 of us have the same watch on. So it's a good quantifying tool.
So what I'd love to... yeah, sponsored by Garmin today. Thank you very much, Garmin. So what I'd like to do is, Josip, can I ask you just to kick us off, please, and perhaps frame for us, when we use the expression population health, how should we be thinking of that in the context of our discussion today?
So population health, before I define this, I would like to say, and you've referred to some of the global issues, is that we are closer to each other, not just literally in terms of phone call away or a cough away, but also in terms of how we influence each other, in terms of lifestyle that we share, in terms of the risks that are generated for our health, as well as things that are helping us to protect our health. And in that sense, we can think of traditional term as public health was some of the biggest improvements that we had in terms of saving lives were just simple hygiene, just clean water, sanitation, vaccination, etc. This is the, if I can say, the past age public health. The modern age public health is really around population health, where that shift is moving also towards relationships, towards how the things that happen outside of the health system, in our homes, in our families, in our schools, at work, interact with what is happening with the health system, how the government, how the industries, how all those things relate to each other and interplay. It's a very broad definition. It's not a definition which has narrow margins, but is trying to encompass the notion of health in a broader sense.
Okay, let me jump in on a couple of things, because Farhana, when you think about the work that you do now and the work that you did previously with IBM, data being such a, let's use the word obvious and critical area when it comes to healthcare. But there's this sensitivity, perhaps more so than in any aspect of our lives, when it relates to data around healthcare. But we know that the more data that we utilize, perhaps the more we can improve outcomes. Is there a role for government to play, and I'm not talking about Singapore government specifically, any government to play in increasing the amount of data that is made available to trusted companies? I don't want to say anybody that applies, that wouldn't be fair. But there's such a restriction in some places on the use of data that advancing things may be difficult. Do you have a perspective from the work that you do on what role government ought to play and where the boundaries might be in terms of making health-related data more available?
Yeah, so fantastic question. And I think, Health Catalyst as a company have worked primarily in the US with very large accountable care organizations, integrated delivery networks, big health systems. And to be honest, the government has not played a big role in a lot of the work we're doing, other than their payment systems, which are incentivizing doctors now to get paid on improvement of health, right? Because at the end of the day, population health management, the simple way I like to think of it is, you take the total population, 20% are typically the very, very sick that account for 80% of the cost, or even 5% account for 50% of the cost. But what about the rest of the 80%, right? And so what we're trying to do in pop health management is really get an understanding of what's going on in those 80%. Are there high-risk patients that are sitting time bombs, that are basically not very engaged in their health, that we need to reach out to keep them healthy? How do we start identifying those different groups? And to be honest, as a government, the way we've seen it is that healthcare data, medical record data, only plays 8% of a role in your overall pop health management strategy, because social determinants of health, all these other mental health, all these other pieces of data actually give you a much more holistic view on individuals. So I think governments, by obviously showing results, and this is something that I've always been a strong believer in, is that if you can show the population, maybe do it on a smaller scale, as a result of having this aggregated data, we've been able to improve health outcomes, we've been able to prevent a certain percentage of patients actually getting diseases. Patients will be more likely to say, okay, this is for the better good. They're not selling my data to insurance companies, right? They're basically using it for the betterment of society. So I'm a firm believer still in an opt-out strategy, meaning that, you know, everyone should be opted in unless you really feel like, hey, I have some mental health issues I don't want people to know about, or, you know, fine. But I actually believe that there's so much benefit of having a holistic view of patient data that actually helps people like Steven do real pop health, which is really understanding not just your medical information, but everything else about you, your income, your education, all those things, whether you're a smoker, a non-smoker, that's not all in a medical record necessarily, right? So to me, governments could play a strong role, but I think they need to show some success and gain trust.
So let me come on, because I always like to do these informal surveys. So Farhana just mentioned opt-out. So obviously, there is going to be you're providing information. Now let's assume, just to make it simple, that anonymity can be assured, right? Before we get into the debate of if I have enough information and enough compute power, I can re-identify a piece of anonymized data. Let's assume for a moment that anonymity can be assured. How many people would be supportive of opt-out, as in use my data for greater research and improving outcomes in the future? Would you say, yes, use my data? And so just, it's a little, because sometimes people are like sort of hedging like a bit. So those that would say, no, it's not the right thing, I'm not a believer in that, somebody against it, or people against that in some way? So either everybody's in or people don't want to raise their hand and say I'm out. But it's interesting nonetheless. And I want to pick up on the point briefly. The World Health Organization, with respect to my friend Josip, I went to the website and just was interested in this. The World Health Organization many years ago defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. And so using that definition, I'll do another straw poll. The complete physical, mental, and social well-being is how we would describe health. Does everybody in the room feel healthy using that? Huh. The answer is not many, right? I mean, according to that.
How many feel that they're sick?
Okay, so using the idea of health in the definition of not well or unhealthy or sick, no. So the interesting thing here is back to this point that when we think about health, a more holistic discussion around it, as opposed to I'm not sick, therefore I am healthy, but the idea of social health, mental health, this whole, if you will, holistic approach. Steve, I know it's important to you. Do you want to share some perspective on how you see it as a clinician as well?
Well, thank you again for asking me to be here, because if you see me typing, I'm not messaging with someone. I'm quite stimulated by what my colleagues have to say. And first, data-driven. Prof. Carr's training assumedly has epidemiology in the background, which is a data-driven science going back hundreds of years to dirty wells in London and the spread of disease. So clearly, there's a mandate for government to be involved, because individually we would not have the resources to solve the problem, nor the individual care to solve the problem. Historically, it's as long as my family's safe, then I'm not going to worry as much about yours. So there's a government mandate. The second thing is, one of the code words that keeps getting bandied about is outcomes. And no matter what the size of the population, if you're asking a question, you're asking an outcome. And one of the greatest failings in medicine is that we don't know our baseline. That you want to talk about an outcome, but you haven't defined what your problem, you know what the problem is, but now we have to work backwards to how we got there. And so we don't have a lot of baseline data, which brings me to my third point. When you share data in the Quest straw poll you ask, that assumes that I broke my hip, I was in the hospital, I'd like to share my information anonymously or otherwise, but why did I slip and fall and break my hip in the first place? Was it too much whiskey? Was it bad steps on Orchard? Was I shoved by someone else? What are the social determinants of health? And if we're only looking at medical data, then you've completely missed the purpose of the definition that you just raised, which means we have to look at what health really means and define it in order to solve the problems of medicine and the cost associated with it. Thank you.
So I do want to make sure that we engage here, but I want to also just push a little bit for the moment just to try and set the stage. Without being too Big Brother-esque, is there a scenario in which we all ought to wear something that is gathering data, environmental, physical? Should I have a genome sequence? Should I know where I'm at, and for people to know where I'm at, and as in pursuit of doing something relevant, not geofencing, so when I walk by a retail shop, somebody knows to ping me for a 5% discount, but more this idea of how do I answer the question that you just posed? Environmentally, do I see a trend that more people have fallen in this place, and so on? I want to try and explore how engaged do we need to be as individuals in pursuit of these bigger social outcomes versus hoping somebody somewhere does something. Josip, do you have a perspective on that?
If I asked you, is smoking healthy or is it okay to smoke, I would look silly because you would say, of course it's not, and I know that. If I asked you some other questions which relate to what is the healthy level of stress? How many hours do you sleep? I'm not sure your answers would be so straightforward, yes, no, or that amount of or this amount, and so on. So where I'm heading is medicine today is a evidence-driven science, and we have certain criteria in terms of what we call evidence, we have levels of evidence, and so on. And what we are talking in terms of now what technology enables, let's say the sensors that count our steps or heart rate and so on, technology is ahead of the evidence, or at least 1 or 2 steps ahead of the evidence. We can measure something, but yet we don't know quite yet what is the meaning for that individual of that measurement. And in this area, it's very exciting because all of this is actually accelerating in terms of developments. We see new and new sensors, new and new opportunities to measure, to digitize everything and anything that we do. And that brings us into the question where healthcare and what is outside of healthcare are starting to shake hands and are blurring the boundaries. The second, you have the blurring between where the human and artificial intelligence are coming together in terms of guiding the decisions around health. So the answer to your question is not straightforward, is layered, and the answer to that depends on specifics.
I want to come on, I'll come back in a second, but Prosenjit, when you think about the role of a startup and an aspiring entrepreneur in trying to do something and provide an answer, a solution, a technology in a space, and then the big firms, the friction for a startup to get into a space as compared to a firm that's more established and knows the rules. So at the risk of causing more challenges for ourselves, we back a lot of early stage companies, but the friction is high. So is innovation in healthcare the remit of big firms, or what is the space available for some very early stage companies when it comes to innovation in healthcare? This idea of technology, what's the role of the entrepreneur?
So my perspective will be mostly a business perspective because I am on the business side of healthcare. And before answering the question, Steve, I would say what I believe to be the core of the innovation: 4 things: data, intelligence, devices, and interoperability. The short answer is, and I'll detail it in a moment from now. The short answer is it's an ecosystem play. We have, and our competitors as well, they have done quite a lot of population health management projects with governments across the world. More often than not, be it telecare, be it surveillance, be it predicting outcomes from disease registries, etc. There is always an ecosystem play wherein there are startups who are agile, who can bring in the social as well as medical devices, if I will differentiate, and who can act and invest on the needs of the market, which is not always very easy for a big guy or a big company like an IBM, Accenture, DXC to go into market and make market-specific investments until they see the returns. Where the big companies play in healthcare is on the interoperability side. Remember, I told about data, intelligence, devices, and interoperability. So the big money, yes, is still there in interoperability. It's essentially creating an ecosystem which works. So let's take an example, like a heart rate sensor put on somebody who has gone out of the hospital after a cardiac surgery. So the sensor takes data, but the data is not useful unless you are putting it under a constant clinical monitoring. And the clinical monitoring is not useful unless you have a provision to send ambulance, unless if any of the parameters go bad. So there is an ecosystem of multiple players, and the bigger companies are focusing on in bringing them all together. So I would say it's a coexistence. It's not a friction that has been successful.
Let me keep my promise and go to you and see if you have questions. I've got some on Slido, but in case somebody doesn't love the technology, anybody want to raise a hand and offer a question before I go further? Okay, then let me go to Slido, and I'm going to interpret one of the questions here. Is there a maturity curve when it comes to population health? This second part of the question, I think, is the part that illustrates. Can governments compare with each other, with other governments, how they are doing with respect to population health? I don't know if there would be examples, Steve, you use the expression baseline, but are there examples where population health and how it's measured and some standardization such that governments can say, you know, I'm doing what I want or I'm falling behind?
Yeah, so I mean, again, it comes down to the baseline, right, as we said. And I think the main thing is governments themselves, I mean, the technology exists, and if they use their data, they can create their own baseline, right? Because, for example, right now, the projects we've done in the US, we're with 500 hospitals, or more like 85 big health networks. Even they don't compare to each other directly, because the way that they are measuring things is a little bit different. So at the end of the day, the way that I would see it is that if you really want to do population health management, you have to look at what is your ultimate outcome. If your outcome is reduced costs, higher quality of care, then you need to actually know what's your actual cost of care, right? And that's what every government needs to actually look at that. And to be honest, it's not that easy to know what the actual cost of care or per patient, how much are they paying every year? And by doing a preventative program, what will be the impact to the bottom line of that, right? And that's the kind of discussions that governments need to have, but to compare government to government is a very difficult thing to do, only given the way that they actually do healthcare, the way that they measure a number of different factors. But having said that, I would want to throw in one caveat, right? I mean, if you take analytics as a whole, if you say for a knee replacement, the average length of stay should be 1 day, I can't imagine why it could be 10 days some country and 2 days in another. There must be, unless there's some significant reason why that one country has a benchmark of 10 days, that's what it is. So there are going to be some standard things that are going to be fairly generic in that sense, that you could probably say, well, yeah, we could compare this lot of areas, but other areas, I think, you know, you would probably most likely end up looking at in-country benchmarks as well.
I think there are valuable cost-effective metrics that physicians and public health experts read all the time. You look at the publications around global burden of disease, Recently, where there was a publication that looked at the number of steps taken. And to back up, no, I do not think everyone needs a sensor. Absolutely not. But there are other ways to get to the information. But using a sensor, a recent publication showed you might think that the number of steps taken by a country on average could be predictive of the burden of disease, of maybe obesity or diabetes in a country, that in one country where they walk a lot, there's less disease. In countries where they walk less, there would be less disease. But in fact, the average number of steps taken by any one country doesn't predict the prevalence of obesity. But if you look at the inequality in the distribution of steps, which gets back to regressing to the mean or looking at the extremes at the same time, the inequality index is highly predictive of the burden of disease, such that a country like Singapore, who, by the way, ranks number 7th globally in that study, whether you're rich or poor, wherever you are, we all tend to walk about the same, and the distribution is a standard curve. But in a country like Saudi Arabia, it's got a very long, curve to the left, which says some groups walk a lot and a lot of other people don't. And that's an inequality in sidewalks. It's an inequality in infrastructure. It's probably an inequality in access to quality food. It's probably inequality in stress and sleep. And so social determinants of health are ultimately what we need to begin to address, not just the outcomes for what's broken, but we really have to start paying attention. None of us can afford for our systems to continue to get sick.
You will know that Bill Gates some years ago decided to create his own Bill and Melinda Gates Foundation. And one of his first questions was, where should he focus his investment in terms of improving health on a global scale? And what he realized at that time is that there isn't really good measurement and comparison. I'll fast forward. I'm part of the Global Burden of Disease Collaboration, which is led out of Washington by Chris Murray, where we measure and compare on many indicators, on many diseases, the populations globally by countries and some on sub-national scale, and try to portray, to give that information, where are we doing well, that we can learn from those, and where should we be putting our effort to improve. And this is seen as vital, and a number of governments are now deciding and saying, actually, this is so helpful to where we should be focusing our policy, that they are sharing their data with us so that we can analyze it and create those comparisons cross-nationally on a global scale. And this is just a really good global example, and this is also resulting then in policy as well as academic outputs, which are published in top global publications in The Lancet and other journals.
Are there questions that you may want to ask? Adrian.
So on to epidemiology, how do you see the fields of epidemiology and biostatistics changing with advanced data analytics? Because there seems to still be a huge chasm between what's happening commercially with data analytics and then maybe academia as well. So how do you see those, perhaps the research side, changing with what's available commercially?
Just in case people wouldn't have heard Adrian's question, if you could please just restate in your words.
Sure. So the question was in relation to epidemiology, how it's changing in relation to what's happening in the commercial sector in terms of the data analytics, and how is epidemiology moving in that sense. I'll give one answer, and that is that the Department of Epidemiology at Imperial, where I come from, has started a couple of years ago a master's in health data science. And data science in terms of the big data analytics and in terms of where you use machine learning and so on is now seen as an essential part of how epidemiology is tackling the global challenges in the field of health. That dichotomy is more catching up rather than dichotomy on purpose.
If I could add on to it, baby steps, but in this region, there is quite a bit of work which is being done on epidemiology and the precursors by certain governments as well as certain corporate offices. One of the examples, one of the ASEAN ministries, they are using polycystic ovarian syndrome advancing to diabetes very effectively to curb the death rate within the maternity death rate. Similarly, there are corporates, and I go back to when Farhana talked about benchmarking. There are corporates who have their higher health education facilities, research facilities basically, corporate healthcare groups having research facilities. They are getting interconnected to share their data and find out insights around epidemiology as well as certain other streams around oncology, nephrology, which are the big bucks from a corporate perspective. So quite a bit of research is being done. It is a bit ad hoc. It is not on the population per se, but on the miniature sample, if I would use for that corporate or for that ministry. However, the real interconnected, countrywide, nationwide kind of an epidemiology study and clinical insight study, we are, as Asia, we are probably still a bit behind than the Western geographies, I should say that.
There was another question.
I have a question around consumer data. I think about 60% of our health outcomes are actually influenced by behavioral and environmental factors. Where do we stand in terms of combining the traditional data, which are the bread and butter clinical data, and the non-traditional data like the behavioral, demographic, and psychographic data?
Those exact data streams I'm not going to address, but I think an equally valuable analogy. A novel data stream would be genetics. And so we know that most of disease today, non-communicable diseases, NCDs, which is 70% of deaths are heart attack, stroke, and cancer on a global scale, most of that is not directly genetic. It is environmental. It is choice. It is knowledge and input around those choices, smoking being an obvious example. But now you can take genetics, not a single gene, but what's called a polygenic risk score, or from a genome-wide association study. And we're talking now not 10,000 or 20,000 or 100,000 genetic traits, but 600,000 to millions of genetic traits to combine to create an odds ratio. This has been done in cardiology and was just published this week for dementia and cognitive decline, where you can take a population and say across the board, you're at relative increased risk for this problem, which again, DNA is not destiny. I don't want you to leave here thinking that you have a gene or a set of genes for a problem, but you can say relatively, one might have a higher risk based on genetics, but you can do the same from your lifestyle scores, from well-validated tools. So the cardiology example, they had a genetic risk score, put people into high, low, and intermediate risk, and a lifestyle score. They had surveyed 50,000 people, and smoking and drinking is on the bad side, and going to the gym and getting good sleep is on the good side. And it turns out that if you're in a low genetic risk and have a favorable lifestyle, we would assign you a risk of 1, a relative risk of 1. And if you're low genetic risk, but you have a lousy lifestyle, then you roughly have a polygenic risk of 2. And if you have a high genetic risk, but a good lifestyle, you're also a 2. And a high genetic risk with a bad lifestyle is a 4. And so you can begin to combine different data streams, whether it's lifestyle as psychographic or lifestyle as your GPS and NETS data, other information, along with this genetic information for you to have a personal map of what you are relatively more or less at risk for, and how does that fit on the timeline of your life? Because it might not matter at age 20, but it begins to matter more at 40 or 50 or 60. And the real takeaway from those kinds of studies is that it shows that lifestyle choice matters. That even in the highest risk group, if you make better decisions about your health, you can significantly reduce your chance of that chronic disease impacting your life. And I think that's where we're going to see a lot of change in these polygenic risk scores, because they're really, really inexpensive, and they're already becoming available to users on apps.
I'll just make one extra comment there, is that, when you look at social determinants, there's been a lot of work bringing that data in, and it's actually quite exciting because your accuracy of your prediction models becomes, it's a totally different ballgame. So I could give you a quick example. If you look at why patients, if you look at your total population, you're trying to reduce readmission rates. Basically, one of the big fundamental, especially with elderly, is whether they have someone taking care of them or not, right? Now, you're not typically going to see that in a medical record. That may be in a clinical note. Somebody may say assisted living or something. Another good example is in the US, they have something called a food desert, which means if the person lives within 2 miles of a fresh food store. Now, if they don't live within 2 miles, they're probably at McDonald's and Burger King, right? Chances of readmission go up, right? And chances of obesity go up. So by bringing in those social factors, honestly, the medical details are there, important, but you really get a much better picture of the patient, and you can really do proper pop health management. And it's already happening. It's just getting access to that data. And as I said, a lot of it sits in clinical notes, believe it or not. Like a doctor will meet a patient, and maybe some of that information will be just put in a clinical note, but it doesn't hit the medical record. That's the reality in most instances.
Can I ask, in the Asian context, how much of this data, the traditional and the non-traditional data, are being integrated in the Asian context?
So I'm just trying to repeat, because so within an Asian context, how much, I'm sorry, I just want to make sure the audience at the back can hear your question again.
Yeah, in the Asian context, how much of the traditional versus the non-traditional data are already combined and integrated to help improve outcomes?
I would say it's still work in progress, but there are pockets of it. So for example, even in Singapore, the Ministry of Health is already looking at bringing in social data. A lot of it requires natural language processing, because a lot of this is sitting in unstructured data. So you have to bring that in. But there's certainly a number of trials going on where we're trying to get it. Singapore has the advantage of a single government that can make some decisions unilaterally that say, let's bring this data together. But in other countries, it's a little bit more challenging. Yeah.
There is one example that probably stands out for this. It's a little company, a little device or app called WeChat. And that's probably one of the best examples of combining social determinants of health, an entire ecosystem that is being built on that platform, including health and medical platforms. So that would be where you would get the combination of information.
Other questions, please? Yeah, you know what? Yeah, thanks. We have a microphone just to be helpful to the other audience members.
Hi, thanks to Steve and the panel. Sorry, I should probably stand. So I'm curious as to whether there has, whether you have any information in either in the data sets that you have, or in the course of your work in this field, as to the impact of climate change on health outcomes now. In the US, for instance, I think there are certain doctors that are very on top of it, especially if they focus on respiratory illnesses. In Asia, that's less so the case at various levels. So I'm curious to hear what your evidence, what your experience is. There is a second part to my question, and that relates to the earlier survey that Steve did just now. We assumed that data privacy is assured. Would Steve and anyone else care to comment on this? Because that's actually a critical point. I worry that going forward, we could discriminate against people with genetic conditions. I'm somewhat biased here, I have to say. But I know there are discussions already that are leading to pretty to outcomes that I would worry tremendously about. So for instance, it would seem perfectly fair to reward people for eating healthily, for not overindulging. But what if healthy food is incredibly expensive? And going forward, given my work in climate change, I worry tremendously that food costs are going to skyrocket at all levels. So are we then going to penalize the middle class and the poor?
We've got a lot going on there, so what I'm going to try and do is, I'm just going to, let's try and come back to the core question at the beginning, whoever would feel compelled. This idea of climate change and doctors that are aware of and seeing the effect in population. Microphone moving its way down the line.
Yep. So I'll take the first part of the question around climate change and the data sets that are being used. Yes, the use is more in US, less in Asia, but few examples that I have been personally seen being in work is, of course, around pollutants and respiratory rates and asthma, prevalence and asthma. There are some good data sets available in, of course, there is available in Singapore and a couple of other countries. How comprehensive it is, I'm not sure, but there are data sets available. On the climate change and the effect of, basically the effect of seasons or the effect of time series on different diseases, we tried for a government in Asia. It was not very statistically significant. However, there is a lot of work to be done because the data sets that we are talking about here are mostly secondary care and tertiary care data. Primary care data is not that integrated in any of the Asian countries. And that primary care medical records will have probably show the effect of climate change and show the effect of other irritants or pollutants in the climate, more than a secondary care or a tertiary care data.
Yes.
I'll just touch, I want to solve the problem on data and how do we manage the health data. Health data, it's likened, or any data is likened to the value of things like oil, like gold, and so on. And we have many examples in healthcare where we can show that at the population level, if data is analyzed, it truly is such. It's saving, it can save lives, it can save millions, and it can improve healthcare, et cetera, et cetera. The question is not anymore, can data achieve this, but can we maximize the potential that this data can achieve? And this is where we come into the domain of how do we manage this data and how do we make it even more personalized to individual rather than using scores and risks and so on, which are on a fairly broad population of you fit those 3 or those 6 categories. But no, what is your personal risk? There isn't a magic solution to this other than saying there needs to be tight governance. We see some differences according to how countries use health insurance. So for example, in UK, where there isn't private health insurance, the attitude towards data and, oh, will this drive my insurance premium up is obviously different. There are different considerations that population has there. I'm not saying that that all the countries should go towards public provision, but that makes it a lot easier in terms of using this data for that purpose. And we had recent examples in Singapore, which is so tightly governed, where data has been stolen, breached, and so on, which are painful lessons and shows it can happen to the best. And really, what can we learn from that, without going to extremes?
It happens all the time. It happens outside of healthcare. your data is never safe. Everyone has the best of intentions, and to say that my laboratory test needs more protection than my IC, than my bank account, than my GPS location is a false statement. One of the beauties of Singapore is that PDPA is not a health-specific recommendation for the management of information. In the States, we talk about HIPAA, and why we would treat one piece of personal information differently than another would be incorrect, in my opinion. Without raising the question of loss of data and piracy and hacking, I always believe that all data is health data. Again, back to your credit card spends, you suddenly stop paying for Fitness First and you've joined a wine and food club, right? You've given up your golf membership in favor of something else. This is going to be highly predictive, potentially, in a social determinants of health. And so all data is health data in that regard. I'll stop. There was something else.
No, I just wanted to add to what Stephen said. My colleague who's a geneticist said that actually, if I shake your hand, I've got your DNA because you basically shook my hand and or if I get a bit of hair. So the reality is there's a paranoia, to be honest, in this world about this, but it's actually very easy. You don't have to go and steal a file. I can sequence you with your hair, right? That's the reality.
That's why we have these coffee mugs here, so that we can make sure we use the gloves when we collect the coffee mugs later so we don't contaminate.
I'd like to go back to the second part of the question, your fear of discrimination. So the reality is the entire insurance industry is built around discrimination. That the meritocracy of Singapore is a form of saying people who get the better grades, not just Singapore, anywhere. If you get good grades, you get to go to a better school. You get different opportunities. And so I don't necessarily want to share a health insurance premium with a smoker. And so nor do I want to have a driver's insurance policy that matches those who have had multiple, infractions driving. And so our behaviors and judging those behaviors, or even just recording them without judgment, allows for discriminating, not in a negative, pejorative way, but putting people into different groups based upon a set of behaviors. There needs to be a safety net, of course. There needs to be controls, and there need to be voices like yours to make sure that the system doesn't get out of control and always looks out for the weaker links. But insurance is predicated, various forms of it, on putting people into different risk categories.
Steve, I think I would encourage incentives to thank you. I think I would encourage behaviors that reduce bad behavior and reduce the nature of negative externalities, which obviously lead to adverse outcomes. But you've also chosen an easy one. So let's take another one. You don't want to be in the same bucket as a smoker. How would you respond then to, say, all the kids with Down syndrome or autism or Asperger's? Or other genetic diseases.
Those are the safety nets that I refer to.
But do we have that here in Singapore?
More so than.
And are they adequate? So there's a whole different.
More than we did 1 and 2 years ago, for sure.
So my takeaway from your comments then would be that if we have to rely on a public safety net, then it would seem that the insurance industry is heading towards a direction where we are going to take that action.
I'm sorry, I didn't hear all that.
You're saying if we require a public safety net, it must mean the insurance industry is trying to more aggressively bucketize or stratify.
Which makes me tremendously uncomfortable, I have to say.
Not necessarily.
It reduces trust in society.
I think that's where government has to step in, and not. There's private insurance and there's a public safety net, or as it's best referred to in Singapore, a trampoline, right? So we want to be there for people, but we don't necessarily always want to just support everyone. We want to give them the resources and the education and the knowledge so that they can deal with the situations they are dealt, and that we as a community can co-manage. Those are the weaker links in the community.
What I'm going to do is, I know Farhana, you've got something. I'm also going to try and move this forward because we have other questions, and then we can talk more on the break. Farhana?
No, I just wanted to add what my colleague said. I think this all comes down to data governance, right? Basically, even if you look at what happened in Singapore, I mean, if they look at the whole COI into it, I think that was the big thing. It was data governance. And I think if you have that in place with an audit trail and specific objectives that you're trying to keep, I mean, there are a million examples of where there has been very minimal data breaches. And to Stephen's point, people are it's AI out there hacking now, right? It's not even people. I mean, it's literally machines hacking. So there's always going to be this concern. But I think if you do put in place a proper data governance, you can avoid and have some level of security in there, right, as well. So I don't want to kind of make it out like, it's free for all. The reality is that you have to have, obviously, security in place.
Without disagreeing with my colleague, I would like to just highlight how big the human factor is. You know who Jeff Bezos is. And if this person, the richest in the world, who surely can afford and does afford protection, security, encryption, and all the other things, has his private pictures shared and photos, then you see that there isn't necessarily a barrier in technology or in governance. There is a human factor, and we are fallible. So I think we need to accept this, and as a society work towards, what we all want is towards fairness, towards supporting those who are weaker, towards society which is compassionate, etc. How this is achieved, a lot of this is achieved by learning on mistakes, and we are all learning, globally, and this is why we are in SGInnovate. We innovate, and there are those who innovate how you hack the innovation. So I think we need to accept this as part of life, and I want to bring us to where the true opportunities of such great excitement of population health and technology are really in transforming the health of populations. And I was just this morning talking to a colleague how for 50 years we worked very, very hard to make our lifestyle more comfortable, reduce the need, from, if you remember, how the TV some time ago, if you needed to change the channel, you need to walk to the TV and then back to sofa and so forth. Now we have remotes. Then the next stage we had now on demand. You don't need to be even there at a certain time. And so what I want to say is we need to re-engineer our lifestyle back to bring the good things in terms of those that support health. And that is movement, and that is reduction of stress, and that is having enough sleep, having a really dark bedroom because it matters, and so on.
So that's back to this idea of holistic health. Yes, please.
I guess that's a nice segue. So thank you to the panel as well for an interesting debate. But in terms of, we've talked a lot about the data and the governance and almost, the sort of analysis of the data. But what would the panel think are the main sort of levers of change to actually drive better public health or engagement with health or, personal control of health? I'm thinking of things like sin taxes or whatever it might be. But what are the levers of change based on the fact that the data is going to say we're all living longer and healthier and happier, sicker lives on average?
And
how are people going to change that?
Can I use moderator's privilege and also add something to the end of that question?
Sure.
Which is, what's the role of any government in trying to bring a population along? By that I mean, if we say evidence shows A, B, C, D, E, therefore we are going to implement a sin tax, and that's sort of the way it is. As opposed to today, some of those things are seen as budgets, which is we want to raise more revenue, so we'll make wine more expensive, as opposed to it's not good for you, so we're going to make it more costly. Is that something that communication and bringing people along with evidence supporting that is a critical part of making this behavioral change possible?
I think that even highly educated people, many are not aware of the value of data that they are generating on a daily basis in terms of digital traces and in all aspects, whether that's they're visiting the internet, whether that's their smartphone and so on. So I personally would be in favor of governments regulating personal data, not just saying it's protected, but actually in terms of going further, how those companies can use this data. And that's very, very loose at the moment, or regulation is, I would say, non-existent. So if Garmin is collecting my heart rate, I honestly have no idea what they are doing with this. You know, I didn't study it. Like all of you, I'll give you an anecdote. A colleague in Canada is doing research on privacy. So they gave people a consent on the health app that they are consenting to donate their kidneys, and if they have already donated their kidney, then they will donate their child, you know. And if they don't have a child, and you know, and 99.7% of people actually consented to this, and only 3 out of 1,000 or something like this came back saying, wait a minute, what are you asking us, you know? What's this, you know? Did someone hack this consent? So, I mean, who reads the consent today? And they are deliberately written in a way that they are undigestible. So.
I think to answer your question somewhat more pointedly, there is no, the syntax is not an answer any more than the carrot is the answer to the stick. Both are required, and you never know what the individual will want on any given day, to have inexpensive apples or expensive truffle fries. And so you have to look at those, but I do think, and what you know, in my own practice, we reverse diabetes and obesity on a regular basis. We have the data to show that. And where it's difficult for me to implement that on scale, and that's what we're working towards, it is absolutely part of our bread and butter day-to-day to do this in my practice. And the reason is, I'm an oncologist, that even though stage 1 and 2 breast cancer has a 98.5% 5-year cure rate, the word cancer is so intimidating that everyone suddenly kind of gets their act together. It's the historical equivalent of an alcoholic bottoming out. Breast cancer, stage 1 and 2, doesn't kill the way people think it kills, but it's a great opportunity for people to reassess the definition of health that you started with, and to say, I was healthy when I was told I had cancer on Monday. On Wednesday, it was surgically removed. On Friday, I'm in the same health. I'm actually cured, but you realize that you haven't been healed. And that's where we're getting back to a holistic view of health, not just the medical side and reducing costs, but the cost side of achieving good health for a population.
I'm going to keep, because I know we're going to hit the wall on time. Yes, please.
I'm going to move on from the data discussion, and let's assume that, you know, we will get there eventually. I want to go to what we're trying to achieve, and it's really this population health, this integrity. We take all the factors that affect an individual's lives, you know, and that's like our nirvana. But I want to also take a look at what has been so far the ability at scale for governments or large stakeholders to act on information. So if I give an example of smoking, we all know smoking kills, yet, you know, cigarettes are not banned. So just as we are working on the technology side and the data side, how do we enable changes or data, you know? Are we also, or is anyone looking at how we're going to enable meaningful change? Otherwise, we're just going to have very detailed information, but...
Yeah, so that is a brilliant question, because that's exactly why I basically joined this company, because the way that, it's exactly your point. Data only tells you where you are. you can compare it to a benchmark, but unless you get that change adoption happening, you're never going to get an outcome improvement, right? And basically, I think the success for analytics in the future is that ability to translate whatever you've identified into something tangible in your healthcare system to actually improve more prevention, get more preventative screenings done, to basically make sure that diabetic patient get his foot screened as well, and also reduce readmissions and all the other things as well. So there are a number of examples where it's actually being used, but I think the big thing with that is that to get transformation, one of the big things that is very difficult to get, but has been transformative in many of the systems that have been successful, is patient-reported outcomes, right? It's something that we tend to use a proxy for something happening, like an outcome. But actually, whether a patient's lives quality has improved or not, I'll give you a simple example. Prostatectomies, right? When you basically do a prostatectomy operation, most of the men end up incontinent, which is a very poor quality of life. And there's many, many cases of this. And there's this one organization in Germany that focused on patient-reported outcomes to find out what actually reduces that, right? Those side effects. And with that information, they changed their care process completely and looked at the way that they were practicing, and they actually were able to reduce that. So now they have like an 89 or 90% success rate of patients that have this procedure, plus reduced outcomes. So I think, if the outcome improvement place is a very, very strong area that I think analytics has to go towards, but I also do think that, with patient-reported outcomes, it's going to get even more accurate in terms of actually being able to improve the lives of patients, because behavioral change is something that is like the magic formula for the world. How do you make a smoker stop smoking, right? I mean, that's a huge one, right? Everybody knows, as he said, stop smoking, but how do you actually drive that change? So I think there's a lot of things that are being done now to actually look at that whole process of either understanding the patient's mentality of what's going on or changing a process within the healthcare system to improve an outcome.
I'm going to go ahead, and then I'm going to take one or two more really quickly, and we'll get to network.
To add on to what Farhana just said, analytics is definitely one of the most important things in this area. The other thing which is becoming more and more important is to deliver the outcomes back to the patients through mobility. So the advent of mobility is actually making the information that analytics is giving us to enable better care at patients' fingertips. One of the examples being in oncology treatment, the nuclear medicine, proton centers are the new buzzwords. A lot of investments are going on. There is a lot of analytics which is going on cancer patients who are attending this nuclear medicine proton treatments regimes. However, the biggest benefit that is delivered to the patient, other than the clinical benefit on a long-term basis, is analytics throwing up the right survivorship care plan and that being integrated back to the patient's mobile device. So for every step of life, patient need not get back to his doctor or his caregiver to know what needs to be done and stuff like that. So that's an example of end-to-end thing where there are new advents in care, which is supported by analytics for better outcomes. And the cohorts that are identified for the better outcomes are actually given information, which is contextual information for a better, long-term care and a better life, so as to say.
Okay, there was a hand in the back, I think, and then I'm going to, yes, please. But hopefully it's a question as opposed to a perspective, because I need to try and get to a point where everybody has a quick wrap up and then we're going to hang out. So yes, please.
Yeah, so on the question of data analytics for healthcare data, do you guys think that are we overusing statistics and data analytics at this stage instead of basic healthcare common sense in terms of the lifestyle diseases? like the number of steps taken. What's true for one person might not be true for another person in terms of their whole entire lifestyle. But are we going for too much statistics like, okay, you should run for maybe 1,000 steps or 5,000 steps, and people are assured that if I walk these many steps, I'm healthy, but that's not the truth always. So are we going too much into detail sometimes when it comes to healthcare data and trying to guide people into what's healthy and what's not?
I think at times that's possible. I think the more expensive the care, as you go down the care continuum, the more information is usually of value, although sometimes it's a simple answer as, a food desert and just find the right person. But one of the challenges of population health, speaking as sort of the quantified self-doctor, just because I like data doesn't mean my patients do. And there are two things that every single person needs to know. And they should learn that at age 25 and look at it on a regular basis. And that is, am I obese or am I diabetic? That's it. And we can do that in Singapore with a finger stick blood glucose and a scale. And we should avoid becoming obese. And we should never become diabetic. Adult diabetes is related to your food choice and your sleep and your mental health. They all do come together. Poor sleep drives diabetes nearly as much as food choice. But if you identify yourself as having poor blood glucose control, then the system should be able to be there to help you understand why that is.
And the choices that you make. Like, for example, I know when you and I've chatted in the past and you have the patch and you can say, this is when I ate the bagel because you can see the spike.
Right.
And so you know that that's a choice.
But it's not always a choice. And so in the sense of the food desert, it's much bigger. It's not just that I chose to, have a donut that morning or that I always have French toast. It's part of the messaging that we allow from food companies. It's the way that sidewalks and parks are structured. Some people don't really have a choice, and it really gets to mental health. I often joke, I ask someone, well, tell me what you ate, and they're like, well, at 2 o'clock I went down, I got a Kopi C and a pastry, and then I was still thirsty, had a Milo, and I'm like, why did you do that? Or why did you go smoking at 2 o'clock? And you talk, and at the end of the day, you realize because they think they're smarter than their boss, that they're just frustrated in some mental health way, and that's the coping mechanism that they're using. So don't underestimate the value of mental health in the social determinants of health either.
Okay, here's what I'd like to do, is there's plenty of time for us to be able to chat more. I think we could take more questions, but I always try and make sure that we have some time together. So I think if there's some takeaways, for sure, data underpinning technology is going to continue to be important, and will continue to be increasingly important because of the fact that we have all these other conditions we spoke about, an aging population, more chronic disease load, and so on. You have practitioners here that represent different capabilities and different experiences. We appreciate all of their input. Our goal for today is not to say, do this, not that. It's just to say, be engaged in it. And I think this choice, when we came back to why is it hard to get smokers to stop smoking, I mean, it's hard when we talk about personal liberties, right? I don't smoke, so my answer is, yeah, for sure, let's not make that available. But if somebody said, let's also not make wine available, then I'd have a different problem, right? So where are those individual rights versus common good? My personal bias is that for greater societal good, we need to kind of get over this idea of hypersensitivity around certain data. There's non-prejudicial legislation already in effect in Singapore, as in insurance companies cannot prejudicially use personal data in a health environment, so there are some frameworks in place. But I agree with my fellow panelists, which is, try as we might, unfortunately, sometimes things happen, and all we can do is make sure that the consequences for misbehavior are clear. but we cannot stop doing these things, just like we cannot stop driving cars and flying in planes, despite the fact that sometimes things happen. And so we learn from those and try and improve. So I hope that we've explored useful topics for you. Thank you for being a part of it, and let's spend some time together now. Thanks.
Are you guys like the...
Yeah, so she was pitching at CXA last week.
Oh, is that right? Cool.
Yeah.
Everyone was trying to introduce us.